Blastic plasmacytoid dendritic cell neoplasm, or BPDCN, continues to be an urgent unmet medical need area in 2021 and beyond. This extremely rare acute leukemia subtype has really found its own home and its own name now in the WHO classification. And my team and I consider ourselves one of the leading groups in this area. I think some of the new issues that are arising and challenges with BPDCN are sort of divided threefold. One is novel targeted therapies in development. We're moving with CD123. We were able to lead the approval of the first and only agent, Tagraxofusp, which is available for patients with BPDCN ages 2 and older in the United States, and now recently an EU frontline approval for adults. And then there is the IMGN632, a novel CD123 antibody-drug conjugate, which is in active clinical trials now in both relapse refractory and, very importantly, into the frontline setting. So CD123 as a proven target in BPDCN, developing novel targets there. Number 2 is the concept of central nervous system disease. This is something that is really starting to be appreciated now in the modern targeted therapy era, as a lot of these drugs really don't cross the blood-brain barrier. And previously, chemotherapy was used in this disease, many of which either had CNS-directed therapy with lumbar punctures or high-dose ARC-based chemo, et cetera. And so we recently published a paper that just came out, EPUB ahead of print, June and Blood of this year, 2021, highlighting this. And we found that 22% of the time, patients with BPDCN will have a CSF positivity rate. Most of the time, almost all are asymptomatic. So it can only be deciphered on a routine prophylactic screening LP. And so because of this, our group is starting to offer lumbar puncture serially in the prophylactic frontline setting, as you would in a patient with high-risk ALL or Burkitt's leukemia lymphoma. So I think this is a big developing story, practice changing, and has already changed our practice here at MD Anderson. And then finally, I believe a third issue in our field of BPDCN is that of stem cell transplant. Stem cell transplant really remains the only true curative option in this high-risk disease. And so I think some combination of all of these active regimens that we have seen work as either monotherapy or single agent approaches. So chemotherapy, in particular, the Cantargian hyper-CVAD regimen, the Tagraxofusp or IMGN, so CD123 therapy, and then BCL2 with venetoclax. And so at our center, we're starting to combine all of these into one sort of triple or total therapy comprehensive approach as we head into the new years. And I think that something like this would be very important. In other words, CD123 directed chemotherapy, venetoclax, BCL2, CNS directed therapy, and then stem cell transplant for young fit patients as sort of a 5-part curative strategy for many of these patients. And then also the development of hypomethylator, such as aza and decitabine for the older unfit patients, and then doublet and triple combinations there with 123 venetoclax hypomethylator that we are leading with our colleague, Dr. Andy Lane at Dana-Farber. And so I believe that we have this whole new era in BPDCN that we didn't have even just 3 years ago, going beyond CD123, beyond monotherapy, into doublets and triplets, and starting to address CNS disease prophylactically and then actively, and then, of course, optimizing timing and types of stem cell transplant.